from the Value Institute, giving us a talk on network analysis applied to healthcare providers. But before I introduce her, let me mention some housekeeping issues. So as you know, all the instructions to obtain CME credit are on the screen. We can also email you the instructions if you provide your address on the sign-in sheet. Our next ID series, so the ID series will be on February 14th, and we will have Dr. Jennifer Taylor from Drexel, who will talk about an innovative application of checklists to ensure safety. And as always, please register through the Christiana Care portal, and the full ID series schedule is posted on our website, ACCEL.org. And finally, the next Tech Talk on March 5th will be Dr. Laura Balzer from University of Massachusetts, and she will talk about machine learning for causal inference. And it's really a great talk. I heard it at a conference, and I invited her, and she was really phenomenal. So don't forget the next Tech Talk. So we are really delighted to have Mina here to give us a talk. Mina is currently senior clinical researcher in the health system optimization core of the Value Institute at Christiana Care, where she's working on healthcare delivery improvement projects. She has a Ph.D. in industrial engineering from Purdue University that she got in 2019, and her Ph.D. concentrated on healthcare analytics. She has an MS in a Master of Science in Industrial and Systems Engineering from Cardiac Moderate University in Tehran in Iran. And she also recently received a Mentored Research Development Award, or MRDA, from our ACCEL CTR. She's a newly minted PhD, but already has a significant list of publications, one of which is in +1, which is quite an accomplishment. And she's also one of the review editors for Health Informatics, more specifically Frontiers in Digital Health Journal. So welcome, Mina, and we can't wait.
Okay. Hello, everyone. My name is Mina. Colleen introduced me. I'm a senior clinical researcher here. And I'm really excited to have this opportunity to talk about network analysis. And I apologize to people who have heard this before and might get bored, but I think network analysis is very useful for healthcare. I use this in my PhD dissertation, and hopefully I'm going to apply this technique to some of the projects that we have here. So, well, first, I have no conflict of interest to declare. Okay, so I want to start by talking about a network. What is a network? Because when I say network, people have different understanding. They think about different things, maybe Instagram, Twitter, LinkedIn, and all of them, they are networks. If you look around yourselves, you see networks everywhere. Like our life is nothing without a network, because that means that nothing is connected. So when we talk about networks, we mean connections between people, things, places, and basically network and graph is the same thing. If you say graph, it's more mathematical, but if you say network, it's most likely relationships between people. So a network is composed of nodes. So we have a series of nodes here, as you can see, and then because it's a network, they should be related. So we have a series of edges or links, or if we think about relations between people, we can call it relations. So these nodes are connected, and we can define these connections between these nodes depending on our problem, however we want to structure our problem. So another thing that we have in network analysis is clustering. For people who work in big data analytics, they're probably familiar with these techniques. When we want to identify a group of, for example, patients who have similar characteristics, we use clustering. There's a similar concept in network analysis as well that you can apply to a network, and you can identify a group of nodes that have similar characteristics, for example, or a group of nodes with stronger connections between themselves compared to the rest of the network. So that technique is called community detection, and it helps us to identify group of people or places that have some sort of stronger connections because of different reasons. Maybe it's their similarities, maybe it's just their stronger interactions. So network analysis is pretty new. Started in the 1990s to really expand to other fields. But It's based on pretty well-established sciences. So the first one, for example, sociology. In the 1920s and 30s, there were a couple of scientists who wanted to apply some measures and analytics to relationships between people. So they started this social network analysis, and it was very simple at the beginning. So the networks that they presented were just small networks, a couple of people, and they could actually do it by hand, which is very different from what we can do with network analysis today. The other thing is in mathematics. If you're familiar with graph theory, it's a very well-established area in mathematics. And also in computer science, if you think about internet, it's the biggest network you can think about. It's so huge that I don't think we can actually show the networks and the sub-networks that exist in the internet. Believe it or not, in physics, we have physicists who actually have developed algorithms for probability detection. And if you're interested, I can send you some references for that. Economics, of course, trades between countries, different types of relations that exist. Bioinformatics, relations between different biological systems, different proteins. So there are also networks. And network analysis, I feel like it's kind of based on all these sciences, but it contributes back to all of them, because the techniques that are developed, the softwares, packages, we can use them in all of these areas. Okay, so for this presentation specifically, we're going to focus more on social network analysis part, because the networks that I'm going to talk about, they're about relations between people. So because of that, we call it social network analysis. So why network analysis? Why do we care about this? Well, network analysis helps us to depict the relation that exists in a complex system. Does it reduce the complexity? No, but we can understand the system better. We can identify people who are important in our network. And what do we mean by important? We can define importance however we want. For example, important to us might be somebody who has many connections, or it might be a person who knows important people. That's another way to define importance. So let's look at this network that we have here. Of course, we just have a couple of people. As you can see from their outfits, they are healthcare providers. And if we want to depict the network of Christiana Care, for example, that would be huge because we have so many healthcare providers. It wouldn't be this pretty. But let's look at these providers. As you can see, they are represented by nodes in the small networks. And there are edges between them that shows their relationships. Now let's look at the edges. You can see that they have different thicknesses. So what do you think that means?
More frequent interactions.
Okay, yeah. So it can be that they have probably stronger relations. So that's why they have like thicker edges. And another interesting thing about network analysis is that it's not about the edges. You can also change the size of the nodes. So nodes that are more important, they have more connections to other nodes. You can make them bigger. You can change the color. There are pretty cool tools like Gephi, or in R it would be harder, but you can use them to show your networks to other people and make them understand it better using just these tools like changing the thickness or changing the size of the nodes. So I'm going to give you an example of one of the measures that we use in network analysis. It's very simple, but I think that's the ones that are most important, and it's for identifying the important nodes in the network. It's called centrality. So what is centrality? Centrality is a measure that helps us to identify the important nodes in the network. And there are many different measures of centrality. We are focusing on 3 here, and they're the ones that I use in my research as well. So we have a very small network here. There's just 5 nodes and there are 5 edges, so it's very small. And we can actually calculate all of those centrality measures by hand. But if you think about bigger networks, we definitely need other tools to help us calculate them. So degree centrality is the number of connections that one node has. This network is not directed. It's an undirected network. There are no weights on the edges. So your networks can be directed. You can have actual directions between the nodes. So an example would be primary care providers who refer to specialists, so there would be an arrow on the edge. But here we just have an unweighted network. It's also not weighted. We don't have any weights. And if we have weights or if we have directions in the networks that change the way we calculate centrality measures, it would be a little more complicated, but with the softwares that we have, we can actually do it. So degree is the number of direct connection between this centrality. Its name is kind of clear. It means how many other nodes one node is between of. Like I play the role of a bridge between other people, so I have control over the flow of information. The other one is closeness centrality, which shows access of one node to other nodes in the network. So if I have a bigger centrality, closeness centrality, I have better access to other people in our network. So for degree, we can just look at the network and we can identify degree for this node, for example, node B as 3, for node C as 2, same for E and D, and for node A as 1. For betweenness and closeness, we have to calculate them. Again, we have a small network, so we can do that. For node B betweenness, we have to calculate how many other nodes node B is between of, and then that would be 3.5, the final number. For closeness, it would be 1 over distances, and the distance is, we're counting the number of edges here. If we had weights, that would be different. So based on degree betweenness and closeness, if you look at all these nodes, you can see that node B is the most central, because it has the highest centrality. Oh yeah. Any questions? So we want to talk about network analysis in healthcare. Again, because in my research, I'm looking at people. I talk about social network analysis. And what network analysis does for us is that it helps us to identify relationships that probably we didn't know they existed. So if you look at your data and you connect people, you see some relations between some providers and some places that helps you to learn more about your system and understand your system better. The topic that I'm focusing on for this presentation is collaboration of healthcare provider, and it's not easy to define collaboration, coordination. In this research specifically, collaboration to me is continuous working of healthcare providers together to provide care to one or more patients. Okay. So did we have any tool before for assessment of collaborations? Yes, we did. But there were surveys and interview, and as we know, they're time consuming. Usually you get a low response rate, and also they're subjective. So if you ask a healthcare provider, how do you work with this other healthcare provider, they provide you their perspective. It might not be wrong, but it's what they think, so that's why it's subjective. But what we do here is we apply network analysis techniques on health data, so it will help us to get an objective picture of the system. Okay, so I also want to talk about how I constructed the networks that I had in my research. I had access to claims data. So claims data, the structure is similar to electronic health records. You don't have access to all this other information about health outcomes of patients in health claims data, but you do have access to patients and their healthcare providers. This is a very simplified table. So patients, providers. As you can see, it's kind of like a bipartite relationships. You have patients, you have providers, and then you can think about relationships that exist between healthcare providers because of the patients that they share. So, for example, provider 1 and 2, they have 2 patients that they share. So we can think about the relationships between these 2 providers, and it can be an edge here. As you can see, that can be graded because they share 2 patients. So this is an edge, they're rated 2. So provider 1, provider 2 collected 2 patients. Same thing, provider 3, provider 2, they have 2 patients as well. Provider 4 and 2, just 1, provider 3 and 4, just 1. And there's a paper that actually validated this approach. They look at relationships of healthcare providers from claims data, and then they ask healthcare provider if they actually had any kind of relationships, formal or informal. And for 80% of the providers, that was true. And with the increasing number of patients that these healthcare providers share, the probability of them having relationships increases as well. So what I did was I just looked at patient sharing relationships of 2 or more patients. The reason was if it was just one, probably, maybe it could have been by chance. We don't know. Maybe we lost some of meaningful relationships as well, but that's the assumption that we made. Another thing is we didn't consider transitivity, which is a concept in network. What it means is that if there's a relation between P1 and P2, and there's a relation between P2 and P3, there's probably some sort of relationships between P1 and P3, but we are not considering that because we're trying to be objective and just looking at the relationship that we can see from the data. Any questions? Another topic that I want to talk about briefly is community detection. As I mentioned before, it's kind of like clustering for networks. It's a huge topic. So if you want to know more about this topic, I have a paper. It's about 100 pages. Very well written. I've read it a couple of times. I'm not kidding. It's wonderful. It's great. It's a beautiful paper. So it talks about all different algorithms of community detection. They can be disjoint, they can be overlapping. Disjoint means nodes only belong to one community. Overlapping means nodes belong to a couple of communities. And you may think, well, it makes more sense if we do overlapping. But well, in reality, if you apply that to a network of 1,000 nodes, it will crash. So disjoint algorithms are the ones that we usually use. And there is no consensus about the definition of a community, what we mean by that. But the definition that I use and the algorithm that I use was based on more interaction between healthcare providers or stronger relations between healthcare providers. And I can also talk about the algorithm as well, but I didn't want to get too technical on this stuff. So we can identify communities. Just think about these groups, and maybe you can think about it as teams in healthcare. Okay, so the hypothesis that we had in this research, the first one is about centrality measures of healthcare providers and the impact on patient outcomes. So the outcomes that we had, they were identified from claims data, so they will not be the best health outcomes, but they sure are an indicator of quality of care for patients. So one is the impact on patient inpatient hospitalization rate. The other is the impact on patient unplanned hospitalization rate. Third one is the impact on patient emergency department visit rates. And the second hypothesis is that there is no change in the centrality measures of healthcare providers from one year to the other. And I'm going to show you a plot so it would make more sense. But basically, we had longitudinal data, so we didn't have just one network. We had two networks, and we could look at the changes in centrality measures of providers from one year to the other. Okay, so let's go to our study design and analysis. The patients that we had, patients with diabetes, hypertension, and hyperlipidemia, we looked at all these patients together because they have similar health utilization. And it will also increase our network of healthcare providers. And we use network analysis, multi-scale community detection, and generalized estimating equations to look at relationships between network analysis characteristics of healthcare providers and patients' outcomes. For healthcare providers, so as you may know, for diabetes or any other chronic conditions, we have so many different healthcare providers who are involved in the care process. And we cannot look at everybody. So we had to consider one healthcare provider and then look at their characteristics and patient outcomes. And the healthcare provider we looked at was the care manager. So how do we identify the care manager from claims data? There is a tool, it's called Johns Hopkins Adjusted Clinical Group. It's basically a tool that provides so many different measures. I can also send you the reference to that if you're interested. And what they do is that they identify measures from claims data. So one of the things that they can identify for you is the care manager, and it's based on number of visits that the patient had to a provider. And there are also other criteria, like for example, when they identify those care managers, they also make sure that it makes sense for that provider to manage care of the patients. For example, to help me with this, diabetes, like if you have primary care doctor, that the patient had 10 visits during 1 year, and another healthcare provider
Cardiologist?
Okay, so it makes more sense for primary care doctor to manage the care. That's a good example. Okay.
So the care manager is not a definition of the claims, it's really a definition that we provide to the healthcare providers who decide the care of patients.
Right.
So most of the time it will be the primary care providers.
Okay. I think. So that's how we identify those care managers. And the measures that we had, so we looked at the degree. Again, degree was the number of connections and now has. We looked at betweenness centrality, which basically shows control over the flow of information for that provider. We have closeness centrality, which shows access of that provider to other providers. Okay, so I looked at those measures in the community, not in the overall network. And I want to be clear about that because we did look at those measures, the relationships of those measures in the whole network and the outcomes, but they were not significant for any of the outcomes, so we considered them in the community. So let's think about that. If I'm a healthcare provider, I have a couple of healthcare providers that I directly and indirectly work with. I have a stronger connection with them, but I may not work with a healthcare provider who is in California as much. So that's why we consider communities, the people who are closer to us, whether it's geographically or because of the plans, there's a stronger connections with these people. So that's why we look at those characteristics in the community. And then the covariates that we wanted to control for patient age, sex, and then the type of provider. By that I mean type of the care manager provider. It could be primary care. So we had like generalists, family practice. We grouped them as primary care. We had different types of specialists in our data, like endocrinologists, cardiovascular. So we call them like specialists. And then there were other providers like social workers, we call them others, just to reduce the number of levels that this categorical variable has, otherwise our algorithm would not. Okay, so outcomes of interest. Again, these outcomes comes from claims data, so a little limited, but emergency department visit, unplanned hospitalization, inpatient hospitalization. They were also identified from the adjusted clinical group from Johns Hopkins. And these do not consider any injury. So that's important because injuries might happen because of an accident, but they're probably not related to that condition. Okay, so we had 3 years of data, 2014, 15, and 16. So what we did was we generated the network of healthcare providers in year 1, which is 2014, and look at the impact on patient outcomes in year 2, 2015. And then we generated a network of healthcare providers in year 2, 2015, look at the impact on patient outcomes in year 3, 2016. Why do we consider this 1-year lab? Because outcomes like hospitalization, they take time to develop, but something like cost, for example, that's pretty quick. So you go to a healthcare provider, you will receive the cost, I guess, after a couple of days or pay there. So it's a quick outcome. So that's why we consider that lab. Okay, so I don't want to get too much into the details of the method, but we use generalist estimating equation regressions. It's different from a simple regression. Many different characteristics that are useful for this problem. For example, it doesn't make any assumptions about the distribution of the data. And the other thing is it accounts for similarities between observation. So what do I mean by that? We are looking at the relationships of provider characteristics and patient outcomes, right? So these providers in the community, they share some patients. Patients who are shared between these providers, they probably have some similarities. And this method allows us to consider those similarities in our calculations. And also, if you look at the distribution of one of the outcomes, the other two the same, you see there's like a curve-like here. Kind of like, you have to really look closely, but it's like curvish. Like a curve. Okay. So it represents negative binomial distribution. So that's the distribution that we picked for this. Okay, so we looked at all patients who had at least one medical claim in year 1, 2014. There were around 20,000 patients. From them using ICD-9 codes, and I was lucky because my population, like the patient population, started in 2014. Still, we had ICD-9 codes. I was so happy. So we had 4,000 patients with diabetes, hypertension, and or hyperlipidemia. We considered from those patients with low medical claim. We looked at their healthcare providers. As you can see, the numbers are pretty similar from year 1 to year 2. There's an increase of 100, but year 2 and year 3, there are similar numbers. All right, so network and communities. So I used R to generate these networks. You can also use Python or Gephi or other softwares. And if you remember, I talked about these 2 patient or more sharing relations between healthcare providers. And that's why you see this number here, which is like 800 or 900 for year 2, but we had around 2,000 providers. So that number reduced. And the number of edges, it also increased from year 1 to year 2. We have a higher number of nodes representing providers in year 2 as well. Components. Another thing that we consider for network analysis, a component is a group of nodes that all nodes are connected directly or indirectly. So as you can see, we had similar number of components. It shows us that the networks have similar structure. It makes sense because these are providers who provide care to the same population for 3 years, and they all have the same type of insurance plans. That makes sense that the network doesn't change as much. And then we looked at the median degree betweenness and closeness for these providers. The reason is networks that are developed based on real-world data, they're usually nodes that have very high centrality and nodes that have very low centrality. And therefore, if you want to use average as a measure, that would probably not be good, but median is a better measure. So as you can see, median degree, pretty similar, 7, 8. Betweenness decrease, and median closeness is similar as well. We applied the community detection algorithm on both networks. So that would help us to identify a group of nodes that have stronger connections. And we have similar number of communities identified in both tiers as well with similar ranges. Again, similar range of communities, a similar number of components in both tiers, basically showing that the network didn't change as much. Okay, so I talked about the outcomes that we were interested in. As you can see here, these are counts. So when you look at counts of hospitalization, for example, or emergency department visit, you don't have many ones if you consider 1 as that outcome happening versus zeros. There are so many zeros because not everybody goes to a hospital, which is a good thing. But we have to consider that when we are modeling our data. So we looked at care managers, right? So we had care managers in year 1, we had care managers in year 2. We looked at their characteristics. But because we wanted to look at their characteristics longitudinally and see if there was any change, what we did was we considered healthcare providers who were common between year 1 and year 2 network. And then we looked at their patients. So we had 167 providers that we looked at, and their patients, 4,230. So, just
Mina, I'm sorry.
Yes.
How did you select the 167 providers?
So, in year 1 and year 2, we have providers, right? And then we identified the care managers in each year. So 212, 214, and then we identify the common ones just to make sure that when we are looking at the changes in network measures, we are being consistent because we can't look at like change in one provider and another provider. That wouldn't make sense. So let's look at one of these just on an example. As you can see for inpatient hospitalization, for example, from 4,320 patients that we had, only 128 of them had a hospitalization. We can consider it as 1 when we are modeling this outcome. Okay, so we had separate models for each of these outcomes. I thought about multivariate, but the model itself is complex enough, and if we made it multivariate, that would be too complex. So we did separate models for each of these outcomes. So the first one on planned hospitalization, and I only have significant variables here, but as you can see, these arrows, pay attention to the direction of these arrows that I have here. It shows that how the relationship is between that variable and the outcome. So, for example, closeness of the care manager in the community, if it increases, meaning higher access to other providers, the unplanned hospitalization will decrease. And for example, here we also had the interaction of care manager closeness with the year. I know it gets complicated, but it means that I'm going to show you a plot. It will make much more sense, I promise. So I'm just going to move to covariates. For the covariates, we have type of providers, specialists, and others. Compared to primary care provider, they had higher number of unplanned hospitalization. Okay. This is not a causation relationship, by the way, just to be clear about that. Just we are looking at relationships, like correlations. So for inpatient hospitalization, we have all the measures in the community, all centrality measures are significant. As you can see, for degree and closeness, if they increase, the inpatient hospitalization will decrease, but for betweenness is different. If it increases, I was surprised the inpatient hospitalization will increase as well. Maybe they just lose control over the flow information. For the covariates, we have patient age. If patient age increases, inpatient hospitalization increases as well. For type of providers, it's similar to unplanned hospitalization with higher number of, with specialists and others have higher number of inpatient hospitalization. Okay. For emergency department visit, we only had betweenness of the care manager as a significant variable. And as you can see, with higher betweenness, we also have higher emergency department visit. In terms of covariates, similar to the other two outcomes, for specialists and other types of providers, for example, social worker, we will have higher emergency department visit as well.
So I'm not sure I understand here, and it's probably this on the previous slide. The number of emergency department visits increase with betweenness, but then when it increases also with the number of specialists, right? Or with a type of, so isn't it contradictory? Or because betweenness means that you have a lot of, if I remember well, a lot of interaction, or you are closer, right?
No. Okay.
No, sorry.
So closeness centrality means access to other providers. Betweenness centrality means you are like a bridge, like you have control over the flow of information. Degree is a number of connection.
Okay.
And then we have all these variables in our model. All right.
Yeah.
Good.
So,
Sure.
how are you? I'm still wrapping my mind around this. So, I don't really understand claims data or a lot of this, but so wouldn't people who are sicker, people, when you're talking about specialists and all these things, like, would they be represented more, have more data points in the claims database? And or the type of institution where there might be a greater likelihood of a care team, people working more closely together. So I'm wondering, I mean, have you accounted for any of those things in terms of the cluster, which is the institutional cluster, and or also, which, you know, like I just said, Austin, I hardly see you, but, you know, so it's not like we work in the same place. We don't necessarily collaborate or see each other, but that might be something in terms of thinking about like macro determinants of some of the things you're looking at. And then I'm not, maybe others in the room could say, but it seems to me like the fact that people are in the claims data, that people who are maybe more sick are represented in the claims data versus ones that, I guess the frequency of contact is not part of this.
Okay, so there are a couple of questions, so let me separate. Everybody who has a medical claims, they're in the claims data. So that's one. So even if you're not that sick, but you went and visited a healthcare provider, you will be in the claims data. So that's part one. Part two, that's a good point about like, if they go to different types of institute and if we can control for that. So if they're sicker, maybe they go to hospitals more. Is that what you meant?
I'm not really sure, but you're looking at networks,
Okay.
and you are using GE because it's accounting for the clustering. And
Right.
there are maybe assumptions that are true or untrue
Mhm.
about what it means to work in systems and like what that means for collaboration.
Okay. So let's think about the clustering that I cared about in this case, because there are different types of clustering that we can imagine. Like patients, we might cluster patients based on the fact that they go to this hospital, that's for sicker people, or they go to this clinic just for outpatient visit. So that's one way of clustering. The clustering that I did here was based on the patients who use the same providers. So that may count a little bit for that fact. Because if like, for example, if these patients are so sick and they're all using specialists, then they're shared between the specialists, so that kind of can count for that.
Again, I'm kind of trying to just even make sense of what's here and what could be like some of the reasons for why you're seeing certain things.
Yeah. So I'm going to introduce a book at the end, and it's wonderful, so
I'll hold my questions.
hopefully.
I'll hold my musing, because they're not really questions.
Okay.
I understand it.
They're good questions. They're all good questions. So let's look at this plot. This is the effect plot because I was talking about the changes in network characteristics from one year to the other, and I know it's hard to understand, like, what does that mean? Because network changes, they change all the time. Our relationships with people, they change all the time. That's why we wanted to look at those changes. So this is for closeness in the community. So let's look at year one. Year one is shown in blue here. So this is closeness of healthcare providers in the community in year one, and then the impact on inpatient hospitalization, you can see in the vertical axis. And then the red one is the community closeness in the community for that provider in year two. So as you can see, with the increase in the closeness in the community, with the increase of access to other providers, the inpatient hospitalization will decrease, okay, for both years. But the impact in year one was bigger than the impact in year two. See the difference here? So that's what I was talking about, like the impact changes the network, the characteristics of providers, how they interact with each other, that would impact the patient outcomes. A little bit clearer. So, okay, discussion points. There's so many things that we can discuss about this, but I pick a couple of them. So we talked about longitudinal networks. So we use social network analysis to think about networks of healthcare providers from one year to the other, how they change. And I personally think for healthcare, it's really important because the different changes that happens in policies, in insurance plans, that would change how healthcare providers interact. So we can use this longitudinal analysis to look at those changes in the network. So that's one point. The other thing is we identified community closeness of the care manager in the community. It's like so long, hard to say. But we identified that as a significant variable. So what does that mean? With better access to other healthcare providers, we can expect better outcomes for patients. And so that's one. And maybe that's because when a provider has better access to other providers, they can better coordinate the care, or they can get information that they need better. The other thing is we have to be mindful about, as I mentioned, the changes that happen, and they will impact the structure of our network. So when the structure of our network changes, all the measures that we get, like centrality, and that's just one of the measures, or density, or all of those measures will be impacted. So we have to be mindful of that. So for example, in my data, what happened was that in year 2014 to 15, there was a change in the insurance plan. So that impacted the structure of the network. And in the paper, we also mentioned that because we see that there is a change in the impact of provider closeness. So maybe that was the reason. Okay, so we identified providers that were primary care to have better health outcomes. It could be that, well, traditionally, primary care providers are the one who manage the care. It could be that patients who went to specialists more, they were just sicker, so they had worse health outcomes. So there are different things that we can consider here, and there are so many healthcare providers here that I don't dare to comment more on this, but you guys can jump in. So we can also consider those that impact the outcomes and the way that we see the relationships between our predictors and outcomes here. So where we can go from here is there are so many different ways that we can move forward. So for example, if we want to implement this result, we cannot just jump in and say, okay, let's do this, or let's just give all the patients to primary care providers because they're better at that. No, we have to probably do some more analysis, maybe do mixed methods, maybe look at the relationships in the real world, maybe go and ask healthcare providers to see if the relationship that we identified actually exists between them. So that would be one. We can do qualitative studies for whatever system that we are looking at. I only had access to claims data, so I got my patient outcomes from the claims data. But if we have access to electronic health records, which we do here, we may be able to expand our patient outcomes, or we may be able to look at other measures, for example, provider collaboration and access to care. So that's another measure that we can consider. And if anybody else has any idea about how to move forward, I would love to hear that, because I'm defining a project and just thinking about how we can expand this research. Okay. So with that, this is a quote from Helen Keller, but it doesn't mean that an individual cannot do anything, but I just like it because I think as a team we can do more. And also, these are the papers that we published based on this research. This is a book, it just came out. Like, I literally got it in my Kindle today. And it's great. Like, if you want to know more, if you're interested and you're very confused, the first course in network science is on Amazon. Very well written for anybody, like with no knowledge, and start reading this book, we will love it. And it's great. So, any questions?
One quick question, just clarifying, I'm sure you said it, but for these, you're looking at this, the claims data just from Delaware, or nationally, or? Yeah, what's the context of the?
Yeah, well, yeah, I should have put it. So it was claims data from one employer. I cannot say like their name or anything, but it was one employer, and we had access to several years of data and looked
So
at
is
those.
it in? I mean, I don't know if you can say, but was it in one single state?
Yes. Mm-hmm. Yeah. I probably can. Nobody would know, but it's just, I'm not supposed to. Yeah. Yes.
A question. So is it, maybe you did this in your analysis, but if a patient, you said that there are about 214 providers, and some were excluded from the analysis because they were not present in both years.
Right.
So what if were there patients, did you look, or is it possible to look for patients who lost their care provider in the first year and had to, I guess, get reshuffled into? Did you look at that in your data, or was that present in terms of someone, because losing your care provider could be, potentially cause that discontinuity?
Right. So let's look at the numbers that we have here. Okay, we have 4,395 patients, okay, that we identified. And then here, we are looking at 4,320. What's the difference? Like, that's not big. That big, right? So we didn't, I don't think patient, I want to know, but didn't lose their healthcare provider. The thing is that we looked at healthcare providers that were like common between year 1 and year 2. Mm-hmm. So patients had their healthcare providers, but maybe for some reason they just didn't go in the second year. So those patients were removed. But that's a good point. But we didn't look at the characteristics because that was a small percentage.
Thank you for the presentation. Very well explained. Now I wrote the book down, so yeah. Question though, this would be very much interesting. I know you mentioned what you're planning to do, but it'd be interesting to see what happens to patients and the network in which they're in for years when it's when their provider services or network is disrupted, like the patients in Hahnemann Hospital or who were connected with Hahnemann. So I'm not sure exactly where, but I'm kind of curious to see if in fact there will be any further studies related to this work to see about those patients and the network and the providers that provided care for thousands of people within, I would say within a small radius in terms of Philadelphia. I'm just kind of curious. I'm not sure if you thought about that, but that's the first thing that came to mind when we were so eloquently explaining networks and the relationships and that type of thing.
Like if there was a disruption?
Yeah, if there was so what happens to networks when there is a disruption like that, of the closure of a hospital, and there are several closures throughout the country, right? But one that's, most recent in terms of near our area is Hahnemann Hospital. And I know from experience with family members that live in that area who've had their providers, they've had relationships with their primary care as well as their specialists, and they all have had relationship with, say, that patient, in the center. Now it's totally disrupted. They were left without any recourse to find and to, I guess, rebuild a new network as it relates to getting the medical care that they need.
That's a great question. So I can think about it this way. Can we record their future interaction with a provider? If we can, definitely that's something to do assessments about, because there's one paper that actually looks at patient level and how the providers of those patients change from one year to the other. I think it's like a 5-year period or something, but I can send it to you. So what happens is they looked at if the community of providers that this patient had changed and how it changed and how it impacted the patient. So this is pretty new, especially the application on larger scale data. So there are a couple of papers that have come out, and I'm sure there will be more. But usually what we used to do in network analysis was using surveys and a much smaller network. So because this is new, there are not many that are looking at this, but definitely that's a great thing.
Yeah, that's a great thing.
Yeah.
And probably using claims, actually, because you can define the claims from the population and see then, a few years later what happened.
What happened to them, right?
What happened to, you need to wait for probably a few years.
Right, because it just happened, right?
Right. That's right.
Yeah.
David?
Fascinating. I have way too many questions.
Go ahead. We have time.
In the criminologic world, this is very, very hot right now in terms of social network analysis. Actually mapping out networks of co-offending groups and then actually trying to figure out how to disrupt those networks by actively severing nodes, primarily through incarceration. And so it's kind of like what you were describing in terms of what is the effect of that.
Yes.
So how would you measure an impact on a network from changes to those nodes or to those edges that are taking place? And just as a quick example of how this was done, there was a really interesting article that was in JAMA for this co-offending network where they took all of the arrests in the city of Chicago and then looked at people that were co-arrested and used that to describe essentially the networks, and found that for firearm violence in the city, 90% of it was contained within a single network that made up less than 15% of the population. Right? And so this concept is there, but that's using arrest, essentially data, and clearly there are structural issues that influence that.
Right.
So I guess a pair of questions. One is, how do you measure the effects of disruptions to networks? And two is, have there been attempts looking at household level social interactions, which I would imagine has perhaps a greater impact than on the provider level?
Okay, good question. So when you say how to measure impact on networks, you mean the overall network?
Has there been an attempt to construct a network analysis of people based on essentially cohabitation in a household, and then relationships within a large, say, healthcare system linked to claims data.
It could be. I'm not aware of that because these stream of research that I've looked at, it's based on claims data and providers collaboration. I haven't seen a paper like that, but definitely there's an opportunity to develop that research. And I think for social determinants of health can be really helpful. But it's important how we define our network. And when we say impact on a network, what do we mean? Because we do have many measures in network analysis, like density, for example. So many different measures, but we have to, this is something about network analysis, we have to pick the right measures. Like if you're thinking about centrality, let's say you want to identify important people in your network that they cause violence. So what does that mean? It means they were probably connected to people who were also really well known and cause violence. So that would be eigenvector of centrality. So what's important is that we pick the right measures for our network. But I would definitely look for those kind of articles and see if I can find anything.
This is kind of a technical question. Could you refresh me on what metric was sort of being optimized or targeted to build the cluster communities?
Oh, the clustering?
Yeah.
Okay. So optimize. Well, we didn't optimize it. So the clustering, we applied an algorithm. I have to show that slide. I know you said it's technical, but let's do that. Okay, so this one. So the algorithm that we use, it's a multi-scale community detection. What it means is that it identifies smaller communities in the network, and they are disjoint. So it's based on the idea of a Markov process. So let's think about it this way. If I throw ink on a surface, ink starts moving, and then it stops after a while. So it means that that's how we identified our communities from this algorithm. So a random walker was trapped in one part of the network for so long. What is a random walker? Very simply, it's an idea in mathematics. Just imagine a person who is randomly walking forward and backward, and it's just completely random. So that's called random walker. Somebody wants to jump in. So that's how we define a random walker. And it's a multi-scale community detection, so it helps us to identify smaller groups. Why do we care about smaller groups? There were other community detections as well, but then they would give us community of 200 providers, just 5 communities of 200, 200, 200. So that would be like a big level. It would not be able to identify the hierarchical structure of the network. Then our network is composed of healthcare providers. And healthcare providers are connected to patients. And those connections, they have weights that are patient sharing. I think I'm feeling like I'm getting away from your question.
No, I'm
kind of make sense?
Yeah. I thought you were maximizing leanness or one of those factors.
Okay, good question. So no, I wasn't maximizing them, but in any community detection, there is a loss function that you try to make. So it gets to that. For this one, it's called stability. So for how long a random walker is trapped in one part of the community. Yeah, that's it. That's the question. Yeah.
So I was a little lost about the random walk part. So what does the random walk algorithm walk within? What is the space?
Network. So it starts walking into the network, and then it's trapped in one part of the network.
So the network of patients or the network of providers?
Providers. So this is a network of healthcare providers. Mm-hmm. The edges represent the patients.
So I also had a technical question, and I'm
no.
sorry. No, it's totally my misunderstanding. So the matrix, the closeness, the betweenness, centrality, do you put them all together in the model, or do you do each of each one in one different model,
Separate models.
a separate
We
model?
have separate models, yeah. I thought about doing a multivariate, but with the generalist estimating equation, it should just be complicated, so we use separate models for that.
But no, the outcome here is a separate model for each outcome.
Right, separate model for each outcome.
But
Oh.
like the betweenness and the closeness, do you put them in the
Oh,
same
yeah,
model?
yeah, yeah. Yeah, we put them in the same. But
I see.
separate models for the outcome.
For each other, but
Yes.
yeah,
Yeah.
these are the same model. So are you worried about collinearity or any interaction between those measurements then when you do your modeling?
I think I checked for that. I don't check the paper again. That's a good question. We looked at the interaction of the measures and years, so from one year to the other, how the change was. But that's a good question. I think I thought about that. I forgot the other response.
I was just curious because they
Yeah.
seem to be kind of related. And so if they are related and all together in your models, then you are exposed to collinearity and that could. But you know, I don't know this type of modeling, so
All right.
I may
That's a good question. Yeah. So you mean that like different measures of centrality they might be
Right. I mean, they might be correlated in a way. Or maybe not, you know, I'm
I'll
just
think about that.
asking.
Do you have a low centrality but a high? Yes.
Yes. But no. They are all centrality. You can have a low degree and then you can have a high betweenness.
I'm not agree.
Yeah. So they don't have to be related,
So
I guess.
they're just different dimensions of centrality.
Right.
Right?
Right.
Yeah.
Because-
So they probably do.
They are not correlated.
No, I can actually show you. I can give you an example. Okay. Okay. So, okay. So let's look at this one. This has the highest betweenness in our network, but doesn't have the highest degree. Because this, if there is no node here, then these part of the network and these part of the network, they will be disconnected.
I see.
But then it is here, and it has a degree of 2, 1, 2. Oh, I have
I
to calculate
see.
the betweenness.
Okay.
That would be so much more. But trust me, it has. Trust me, it has a degree of 2. Like this node has a degree of 1, 2, 3, 4, but the betweenness of this one is much higher compared to this one.
So, like, is it safe to say that these three measures are completely independent?
Safe to say, I wouldn't. I'd have to do some calculation. That's a good question.
All right. Any other questions? Great. Well, thank you again.